Hello everyone. In this video, we'll be talking about multiple sclerosis. It is one of the demyelinating diseases of the central nervous system, and it is an autoimmune disease. Demyelinating means there is loss of myelin sheath from neuronal axons. Myelin in central nervous system are produced by oligodendrocytes, and myelin in peripheral nervous system are produced by Schwann cells. And remember, biochemical abnormality in the content of myelin is called leukodystrophy. Briefly revising the physiology, this is a structure of a typical neuron, and you can see axon is covered by myelin sheath, but it's not fully covered. There are some exposed parts of the axon called as nodes of Ranvier. The myelin sheath acts as an insulator, meaning the part of the axons covered by it cannot depolarize. Hence, it's the only nodes of Ranvier that can depolarize since the sodium channels are concentrated in this part. So instead of a steady conduction of the impulse tends to jump from one node of Ranvier to another. This saves the energy and makes conduction more efficient. This type of impulse conduction is known as saltatory conduction and is possible only in the presence of myelin sheath. Now let's see how this physiology is affected in multiple sclerosis. So coming to the pathophysiology section, as I said before, multiple sclerosis is an autoimmune disease, so there has to be a role of immune system. That's where the antibodies and the T cells come into play. Together, they attack the myelin antigens, specifically myelin oligodendrocyte glycoprotein MOGP and myelin basic protein MBP. This leads to loss of myelin sheath. Hence, there will be no saltatory conduction. Instead, there will be continuous propagation of the impulse, which is far more less effective. It is also chronic inflammation causing demyelination. The main cytokine involved is interferon beta. Later, it causes gliosis or scarring, followed by secondary axonal injury and later on even cerebral atrophy. Multiple sclerosis exclusively occurs in central nervous system. No PNS or other systems are involved. In the classification, it is classified into 4 types. First is benign multiple sclerosis. It has best prognosis, but sadly it is rare as compared to others. This type can present as episodes of attacks, but there is no any sorts of disabilities in between the attacks. So the patient returns to absolute normal after the attack. Next is relapsing remitting type, which is the most common type, standing out to almost 85% of the disease. It also has good prognosis. So in this type, the episodes of attacks come and go, just like in benign multiple sclerosis, and the patient returns to normal but not completely. Next is secondary chronic progressive type of multiple sclerosis. It is also rare and has bad prognosis. In this type, after few attacks, there is steady increase in the disability. Lastly, there is primary progressive multiple sclerosis. It is the second most common type and has very bad prognosis. Because here, there is steady increase in disability without any attacks. Now the risk factors, or some of these you can include in the features. Females are more affected than males, and it's mostly seen in age group between 20 to 40 years of age. Risk increases if one of the identical twin has multiple sclerosis. It has been associated with vitamin D deficiency and herpes simplex virus 4 infection. And also, since it's an autoimmune disease, it is mostly associated with other autoimmune illnesses. Now on to the presentations. Since it is a disease of central nervous system, the organs affected are brain and the spinal cord. And sometimes the optic nerve can also be involved, presenting as optic neuritis. Most common presentation is sensory presentation, followed by optic neuritis, then motor presentation being third most common, and we have autonomic presentation. And rarely there can be spinal cord syndrome, which presents as acute transverse myelitis, and it's more common in primary progressive type of multiple sclerosis. The sensory presentations could be in the form of paresthesia, hyperesthesia, tingling, and numbness. Motor presentations could be spasticity, exercise-induced fatigue, and rarely weakness. Bowel and bladder dysfunction present as autonomic presentations. These three can be included as long tract symptoms. Then optic neuritis is due to demyelination of optic nerve. There can be painful loss of vision and diplopia. Brainstem presentations include ataxia, tinnitus, and vertigo. Multiple sclerosis can present with some positive symptoms. Let's see what are they. First, there is Uthap's phenomenon. It is abnormal heat sensitivity, classically presenting as unilateral visual blurring in hot shower. Lhermitte sign is not specific to multiple sclerosis. It is also seen in cervical spondylosis. So here, flexion of the neck produces an electric shock-like feeling radiating to the back and then to limbs. Facial myochymia means abnormal facial flickering. And lastly, we have glossopharyngeal neuralgia as a positive symptom. So these were the positive symptoms of multiple sclerosis. Now we come to the investigation part. The best investigation is MRI. We look into T2 flare MRI because the inflammation appears bright here. So we look for hyperintensities in MRI in areas of central nervous system like paraventricular area, juxtacortical, infratentorial, and spinal cord. Out of these, the most common area is paraventricular area. And also, sometimes the lesions in the paraventricular area are arranged in a finger-like projections around the ventricles, which are also called as Dawson's fingers. Now let's talk about McDonald's criteria for diagnosing multiple sclerosis. Here we observe the number of attacks, the number of lesions, and additional criteria for diagnosing multiple sclerosis. If the number of attacks is 2 or more than 2, and the number of lesions is 2 or more than 2, then we can simply diagnose it as multiple sclerosis with no additional criteria required. If the attacks are 2 or more, but the lesion is only 1, then we should look for dissemination in space on MRI or wait for further attack to diagnose multiple sclerosis. Dissemination in space means presence of 1 or more than 1 lesion in at least 2 out of these 4 areas. If there is only 1 attack with 2 lesions, then we should look for dissemination in time on MRI or wait for further clinical attack. Dissemination in time means appearance of new lesion in a follow-up MRI. If only 1 attack and 1 lesion, look for both dissemination in space and time. The next investigation that can be done is collecting CSF by Spinal Tap and looking for oligoclonal bands. These are intrathecal IgG bodies and are detected by immunofixation electrophoresis. There is also increase in CSF protein. The treatment of multiple sclerosis is very complex, but to simplify it, for acute attacks, we use IV steroid, that is methylprednisolone, 1000 mg for 5 days. And for prevention, disease-modifying therapies are used such as interferon beta, glatiramer acetate, fingolimod, or natalizumab. So that's it for multiple sclerosis. Thank you.